Dear Professor Cao, Professor Sheikh, Professor Krong, Professor Xu, and dear colleagues here, good morning. It is my great honor to give this opening speech today. Like Dr. Cao said, that many of us have had conferences on medical education in recent years, but discussion are still needed, much needed, to reach consensus, especially in the rapidly developing world. And in that, I think medical education is at least one of the most challenged fields over the past decades. And thanks IGHPE for your organizing of this important conference in China. And taking this opportunity, I would like to share with you our projection on medical education's evolving based on our understanding, thinking, learning from brother and sister institutions, both abroad and domestically, as well as our research and practice in Peking University Health Science Center. First, a diversified team of health professionals are more and more needed as medicine goes from providing hospital care only to safeguarding, monitoring, and rehabilitation of health. Medical education is expected to produce a wider range of health professionals and transdisciplinary experts. Thanks to the leaps and bounds in which medical technologies have advanced over past almost 100 years, what medicine can do has been greatly expanded. However, it is not without problems. Increased costs, human work replaced by machines, excessively focused specialties, and technicianism. Most importantly, technology progress does not cover all of the diseases, and non-communicable diseases, NCDs, which counts for almost 70% of all cases, still rely on effective and long-term prevention, disease management, and rehabilitation. NCDs are now still a major bottleneck for prolonging life expectancy. And care alone, in particular, technology in intensive tertiary care alone, is not capable of meeting all the health needs. Training of the health professionals in primary care, for example, GP, in prevention medicine, nursing, rehabilitation, and public health is therefore a clear path forward. Second, the whole person education of medical students needs to be more emphasized nowadays. As medical science and technology expands, so does the content of medical education and the implication of competency. At the same time, for all of the breakthroughs, medicine still is far from omnipotent, and those who practice medicine are only human. There is still as much truth in the aphorism to care sometimes, to relieve often, to comfort always. As it was first phrased a century ago. Hence, the competency-oriented approach aiming as a whole person education. This approach does not stop at knowledge impartment and skill training, but goes on to help students build professionalism, humanities, teamwork, critical thinking, problem solving, and global view, and so on. These dimensions of competency come not from textbooks and lectures only, but from an enabling environment, an environment that gives students supervised exposure to practice, society, and to people. It is an environment where students can learn by observing their mentors and role models. And so a faculty made up of competent professionals is vital for the competency of the students. To deliver this approach, a better targeted students' assessment system has also to be put in place. Hard as it to test a student's competency, well-designed exploratory efforts toward this direction will pay out on the long run and bring about long-lasting benefits. Third, we need integration. This concept is three-faceted. First, a holistic approach to health. Delivery of this approach requires awareness from the whole society so that all health-related authorities and even industries may work together for promoting of health. Then, integration of medical knowledge. The discipline of medicine involves input from science, engineering, social science, sociology, and humanities. However, it is science and engineering that dominate the methodologies of medicine, while sociology and the humanities are left at the margin. For instance, the combination of epidemiology and the statistic in clinical setting is key to identifying causes of disease and overturning better outcomes of treatment. This critical piece of research capability needs to be started at school and last for the whole continuing education of medicine. And the integration of disciplines beyond medicine. Training of transdisciplinary personnel and collaboration of multidisciplinary teams will also provide human resources for concerted response to public health emergency, reform of the health system, as well as innovation of the health industry. Fourth, the curriculum reform. Medicine is a practice-oriented discipline, as you all know. The best practice of medical education has evolved from discipline-based learning to problem and organ-based learning. A new round of education reform should also keep up with the wave of information technology and the digital revolution. This doesn't mean that total replacement of doctors and hospitals by machine and by telemedicine, but at least new possibilities to empower students with better access to knowledge and facilitate doctors in their continuing education. As educators, we should embrace this trend. I'm so happy that this conference will cover many of these challenges we are facing. We are gathering here to share with and learn from each other. And take this opportunity, I want to say thanks to Dr. Cao for your leadership in medical education and in the whole medicine. I still remember and appreciate the consultation you've offered us at Duke at the beginning of Peking University Health and Centers education reform. And your suggestion 10 years ago, I'm so happy it is now the time finally for us to practice. And thanks to Professor Sheikh, Krong, and Professor Xu, and everybody who make your efforts to make this conference possible. And thank you for the nice arrangement of this meeting. I like this situation. It is good for us to discuss deeply. And I'd also like to thank my Chinese colleagues for your participation. Together, we can achieve a better future, I hope. Thank you.